All right, everybody. In case you don't recognize my voice, this is Scott Cardoni, one of the PGY3s EMIM. I'm giving you a quick update on pharmacologic treatment of COVID-19 as of the 7th of April, 2020. Thank God this isn't in person so that you don't all have to witness the very weak mustache I'm growing as part of Dr. Howard's contest. So we can just quickly go over the current OSU guidelines for treatment of patients with COVID-19. The mainstay of therapy is going to be supportive care for all patients. These are things like oxygenation and ventilation, which I think are adequately covered by a couple of the other talks by some other residents. A couple other key things to hit. With regard to fever control, we prefer Tylenol. There's some data that says NSAIDs could potentially be harmful. It's not great data, but reach for Tylenol instead of NSAIDs. We also know that COVID patients are starting to look like they might be a little bit hypercoagulable. So getting started on thromboembolic prophylaxis like Lovenox or heparin subcutaneously is going to be pretty important. And then finally, some information that's coming out of some of the hospitals in New York that are seeing a high volume of these patients. Acute kidney injury is very common with COVID, but it looks like it's not a pre-renal AKI. It is an intrinsic renal injury related somehow to the action of the virus. And a lot of patients have gotten boluses to try to treat the acute kidney injury, only to accumulate that fluid on their lungs and then have worsening respiratory status. So far it looks like the better thing to do is to avoid reflexively giving boluses for an elevated creatinine and instead reserve boluses only for patients who have a clear indication, such as obvious dehydration or hypotension. As far as pharmacologic therapy, there's a number of things that are under investigation globally. And at Ohio State, we have a few kind of hard indications for when to consider some investigational pharmacologic therapy for COVID, namely ventilated patients in the ICU who are either immunocompromised, over 60 years old, or under 60 with certain comorbidities such as chronic heart, lung, kidney, or liver disease, bad diabetes, pregnancy, or active cancer. You can also consider treating patients who don't meet those strict criteria, such as floor patients who are over 60 with those comorbidities, or floor patients who have immunocompromise. And these patients are all either folks who have confirmed COVID by swab or who are highly suspicious. You don't have to wait for the swab necessarily to start these treatments. However, you do need approval from the Antibiotic Stewardship Program, or ASP. You can find that pager number on WebExchange. However, most of the time these treatments are going to be started in the ICU. A lot of them, as we'll see, are going to need approval from the intensivist and from infectious disease as well. So the first-line therapies that we're using here at Ohio State include hydroxychloroquine, remdesivir, and Kaletra, which is a combination HIV medication. Hydroxychloroquine is essentially the first-line therapy out of the three options. It is basically what you're going to use in all comers who meet indications for treatment. The main risk of hydroxychloroquine is QT prolongation. So this is something that you'll need to start patients on cardiac monitoring and aggressively correct their electrolytes, K greater than 4, phos greater than 3, and mag greater than 2. Remdesivir, this is approved by the FDA for compassionate use for intubated pregnant patients. And my understanding is that this has to be shipped to us, so this is not something we could really realistically start in the emergency department. There's some forms that have to be filled out, it has to be approved, and then it has to be sent. And so patients who are waiting to start that drug will either start on hydroxychloroquine or Kaletra while they're waiting for the remdesivir to get here. Finally, Kaletra, that's a combination of lopinavir and ritonavir. Those are protease inhibitors, I believe, HIV protease inhibitors. That's essentially an alternative to chloroquine when patients already have a long QT or have a known long QT syndrome, or if there are pregnant patients waiting for remdesivir who can't take chloroquine for whatever reason. As we'll see, the data for Kaletra is not very promising. It also has pretty strong drug-drug interactions, so this is something to, if you're thinking about starting this, you need to quickly review the med list and maybe chat with a pharmacist down in the ED. Also, if you don't know a patient's HIV status, send that. You don't need to delay starting this treatment, but it's something that the floor team is going to want to know. As far as second line therapy, there's tocilizumab. I hope I'm pronouncing that right. That's a monoclonal antibody against the interleukin 6 receptor. Um, this is essentially reserved for ICU patients after failure of the available first line investigational therapies. It's thought to try to tamp down on the cytokine storm that we think is what's causing critical illness in COVID-19 patients. This is one that also requires approval of both the intensivist and the infectious disease team that will be consulted on the patient. So this is, I think, probably highly unlikely that you'll ever have the opportunity to start this in the emergency department unless we get some more data and it becomes a first-line drug. If this is something that you're going to end up starting someday, it's important to send off some baseline labs. We'll be trending an interleukin 6 level, CRP, D-dimer, fibrinogen, and ferritin levels weekly while they're on tocilizumab. And so the team that takes care of them upstairs is going to need a baseline set of levels to work with. All right, so to the meat of my little talk, the data on all these treatments. So first, the best data, and unfortunately this is still pretty terrible data, but the best data is for hydroxychloroquine. So just to review, hydroxychloroquine is an antimalarial and immunomodulator used in conditions like lupus or rheumatoid arthritis. The mechanism for COVID is not very well understood, but we think maybe its immunomodulatory properties are improving the cytokine storm. So there's a handful of studies. None of them are all that great. The first one that I'm sure most of you have probably seen at this point is a French study. This is a 22 patient study by Gautret that essentially the only outcome they looked at was viral elimination, meaning when did the patients have a negative swab. There were no clinical outcomes reported and there was no real control. The test group was controlled against reported outcomes from patients treated with supportive care at other institutions. Regardless, this is what generated all the excitement about hydroxychloroquine, even though the data is obviously not very good. To follow that up, there were a couple of studies in China. The first is this Jun Chen et al. It's 30 patients, randomized 1-to-1, chloroquine versus supportive care, and it didn't show any significant effect of chloroquine on viral clearance, fever resolution, or chest CT findings. Another randomized study was this Zhao Chen. This was a 62 patient study, again randomized 1-to-1. And this one did show a pretty good effect of chloroquine on time to clinical resolution, fever resolution, cough remission, and radiographic improvement, both on chest X-ray and CT. However, all these are all pretty small studies. The data clearly is pretty equivocal. There's some promise there, but it's certainly nothing earth-shattering. And there's 10 small randomized controlled trials globally that are underway, so we should hopefully have more data on chloroquine in a matter of a couple of weeks. The next one is remdesivir. This is the drug that was developed for Ebola. Its metabolite inhibits RNA replication, and this was developed for Ebola and then showed some promise during SARS and MERS. So there was some excitement to use it for COVID, and this is the one that's being used compassionately for intubated pregnant patients right now. The data for COVID is unfortunately limited entirely to case reports. There's not really any good data, not even as good as chloroquine data. But there is a large phase 3 double-blind randomized controlled trial that's enrolled 308 patients and should be set to conclude near the end of the month. And so hopefully we have some good quality data hopefully pretty soon. This is Kaletra. This is the antiretroviral combination pill that did show some in vitro activity against SARS, and there were some animal studies showing some activity against MERS. We did have a fairly large randomized controlled trial of nearly 200 patients that unfortunately showed no benefit to Kaletra. So at this point, most authors are saying there's not really any role for Kaletra in COVID. It's still listed among the first-line therapies at OSU. I think mostly because we don't really have anything else. And this is one that's relatively easy to get, since it's in widespread use for HIV already. But it doesn't seem like there's really any data at all to suggest that it's going to do any good for COVID patients. It seems like use of Kaletra in COVID is being phased out. As far as tocilizumab, this is that IL-6 receptor blocker that we think is helping with the cytokine storm and critical illness due to COVID. This data, again, is really largely theoretical, and there's a handful of case reports and then one case series. This was out of China. There were 20 patients given tocilizumab, and they all appeared to do pretty well. I think 19 out of the 20 went home, but there was no comparison arm in this study, so there was no control, and none of the patients' outcomes who got tocilizumab were not compared to outcomes of patients treated with standard of care. So it's not really clear from any of the data whether tocilizumab is helping, but anecdotally, it seems like there's some benefit. There are numerous randomized controlled trials underway for tocilizumab, so hopefully we'll have some more data on this one soon, as there is a fair bit of excitement about this, and it does seem promising based on the anecdotes. Finally, there's a lot of talk about use of convalescent serum. So folks who've recovered from COVID-19, who have antibodies now against the virus, donating their plasma to be infused into patients who are currently critically ill to try to help them mount a better immune response. There is one single case series of 5 patients in China who were treated with convalescent plasma. This is not a controlled study. It's just 5 patients who had already received antiviral agents, steroids, and were all mechanically ventilated. Most of them were younger, and it looked like they did reasonably well. ARDS resolved in 4 patients out of the 5, and 3 of the patients were able to be extubated within 2 weeks of treatment. 3 of them got discharged from the hospital. 2 of them are still stable in the hospital. A brief word about a couple of drugs that we're not using. Azithromycin, that's been brought up as part of a combo with hydroxychloroquine, but that study again didn't look at any clinical outcomes, and there's no evidence that says that there's any clinical benefit to using azithromycin in COVID, and there's previous studies for similar coronaviridae such as MERS or SARS that show no benefit. We're also avoiding steroids unless there's a hard indication such as a COPD exacerbation, or you're using it as a stress dose steroid for refractory septic shock. There is the potential for prolonged viral replication if you give steroids, so that's why we're avoiding it unless there's another really good reason. Tamiflu has also been brought up, but there's no in vitro activity against coronaviruses, so really only use that if you suspect co-infection or confirmed co-infection with influenza, and Dr. Cade would probably tell you that even then it doesn't do anything. There's also been some discussion about danger with ACE inhibitors and NSAIDs. Our institutional policy is to make decisions about ACE inhibitors independent of COVID and not to worry about that one. As far as NSAIDs, there is some potential, we think, for NSAIDs to exacerbate the disease, so try to use Tylenol instead of NSAIDs. That is all I have for you. I hope that was helpful.